Okay, so let's unpack this. Imagine your body's security system. This highly specialized, really tightly controlled force of white blood cells.
Right.
Today, we are diving deep into Chapter 24 of Porth's Essentials of Pathophysiology. We're going to figure out what happens when that whole security system kind of breaks down.
Yeah, breaks down is a good way to put it, from like simple defenses just going missing.
All the way to the ultimate disaster.
Yeah.
Uncontrolled proliferation. Cancer.
That's basically our mission for this deep dive. This chapter, it's pretty comprehensive. It moves step by step through all these disorders of the lymphoid and hematopoietic tissues.
Okay.
So we're going to try and give you a framework, a way to understand this whole spectrum. And it really runs from basic deficiencies, think leukopenia,
Right.
all the way up to the really complex malignancies, the leukemias and the lymphomas.
And the framework itself, conceptually, it's pretty simple, isn't it?
Mm-hmm.
When we talk about problems with these cells, they generally fall into two big buckets. Either it's leukopenia, where you just don't have enough leukocytes, a deficiency.
Right, a lack of cells.
Or it's proliferative disorders, meaning you have too many cells. And that proliferation, well, it could be reactive, maybe due to an infection.
Or it could be neoplastic.
It needs cancer. Exactly.
So the key to really understanding these diseases, I think, is starting with the normal development process. How are these cells supposed to work?
Makes sense. Where do they come from?
Well, all white blood cells start out as these pluripotent stem cells deep inside the bone marrow, and then they choose a path, one of two main developmental lines.
Okay, line number one.
That's the myeloid line. Think of this as the factory for all the immediate responders, your granulocytes.
So neutrophils, eosinophils, basophils.
Exactly. And also the monocytes and macrophages, they're like the shock troops, the first ones on the scene.
Got it. And the second line?
That's the lymphoid line. This one gives rise to your more specialized forces, the T cells, the B cells, and the natural killer, or NK cells. And when we talk about cancer in this whole system, a really common theme is often this uncontrolled proliferation of the immature precursor cells.
Ah, the blast cells you mentioned.
Precisely. We collectively call them blast cells, like myeloblasts from the myeloid line or lymphoblasts from the lymphoid line. Knowing that term is, well, it's essential for diagnosis.
And it's probably good to remember that this production, this leukopoiesis, it's not just random, right? It's controlled.
Oh, absolutely. It's precisely controlled by chemical signals, these things called hematopoietic growth factors, like GM-CSF is a big one.
What does that do?
That's the signal telling the bone marrow, hey, we need more granulocytes and macrophages, stat.
Yeah.
Usually happens during infection.
Right. Okay, so they all start in the bone marrow, but they don't all finish there.
Exactly right. Their finishing school differs. B cells, they complete their maturation right there in the bone marrow.
Okay.
But the T cells, they have to travel. They migrate to the thymus gland to fully differentiate into the mature helper T cells and cytotoxic T cells we need.
And understanding the anatomy of where these cells hang out later, the secondary lymphoid tissues, that's crucial too, isn't it? Because that's where the trouble often starts with malignancies.
Absolutely critical. Think about the lymph nodes. They aren't just random blobs. They have a structure. Organized B cell and T cell domains.
Like the B cell cortex with its follicles.
Exactly. And inside those follicles, especially when they're active, you find the germinal centers.
Ah, okay.
These are reaction sites, busy places where B cells are working hard. And importantly for us today, they are the precise origin point for many types of lymphomas.
And we should also mention multi.
Yeah, yes, definitely. Mucosa-associated lymphoid tissue. It's basically unencapsulated lymphoid tissue standing guard right at the body's entry points, gut, respiratory tract, ready to fight invasion.
And lymphomas can start there too.
They certainly can. It's another potential origin site.
Okay, so that gives us the baseline, the normal function. Now, let's pivot to that first bucket of disorders, the deficiencies, the absence of cells.
Right. So leukopenia means the overall white count is low. But clinically, the most dangerous problem almost always stems from the lack of neutrophils.
That's specific type, so we call that neutropenia.
Correct. Defined as having an absolute neutrophil count, or ANC, below 1,000 per microliter. And since neutrophils are really your primary defense against bacterial invaders...
Having too few is a serious vulnerability.
Extremely serious.
And there's a critical number, isn't there? A threshold.
Yes, and this is a number you absolutely have to remember clinically. An ANC below 500 cells per cubic millimeter.
500. Why is that number so important?
Because it's basically the line in the sand. Below that, the patient has effectively lost their main defense system against bacteria. Their infection risk just skyrockets.
So you have to take special measures.
Absolutely. Strict neutropenic precautions become necessary. We have to manage their environment carefully, not just try to boost their counts. And if the count drops almost to zero,
That's a granulocytosis.
that's the term, virtual absence of neutrophils.
Okay, so what causes neutropenia? Can you be born with it?
You can, but it's very rare. We call that congenital neutropenia. Often involves mutations in a gene called ELANE.
And there are different types.
Yeah, there's severe congenital neutropenia, sometimes called Kostmann syndrome. It's tragic, really. The maturation process just halts at an early stage, the myelocyte stage.
Leaving the body unprotected.
Exactly. And sadly, these individuals also have a significantly high risk of developing acute myelogenous leukemia, or AML, later in life. There's also cyclic neutropenia, which is different. The counts oscillate periodically.
But most cases aren't congenital, right? They're acquired.
By far, yes. The vast majority of neutropenia you'll see clinically is acquired, and the common culprits, usually things that suppress the bone marrow.
Like chemotherapy.
Chemotherapy is a huge one. Also, certain drugs can trigger immune reactions where the body's own immune system starts destroying neutrophils. It's an idiosyncratic reaction.
Any other causes? Autoimmune.
Definitely. Autoimmune conditions can do it. Felty syndrome is a classic example mentioned in the text. It's this sort of triad.
What's the triad?
Splenomegaly, an enlarged spleen recurrent pulmonary infections, and the neutropenia itself. Seeing those three together should make you think Felty syndrome. Infections themselves, especially viral ones, can also cause temporary neutropenia.
Okay, so that's what happens when cells disappear. But sometimes the issue isn't absence, it's a virus hijacking the system, leading to overproduction, right? Like
Yep.
infectious mononucleosis.
Yeah, that's a perfect example. It's a classic self-limiting lymphoproliferative disorder. Not cancer, but too many lymphocytes for a while.
Caused by EBV.
Commonly caused by the Epstein-Barr virus, EBV. It's B lymphotropic, meaning it specifically infects B cells. And once you're infected, that virus actually stays dormant in your B lymphocytes for life.
Wow. And the symptoms. I think most people know the basics.
Yeah, it's usually an insidious onset, takes a while to show up, maybe for 4 to 6 week incubation. Then you get that classic triad, fever, pharyngitis or sore throat, and generalized lymphadenopathy.
Swollen glands, especially in the neck and groin.
Exactly. Cervical, axillary inguinal nodes are commonly enlarged.
What about complications? Is mono dangerous?
Usually not, but the complication always highlighted is splenomegaly, an enlarged spleen. This happens in like 50–60% of cases.
And why does that matter?
Because there's a rare but very critical risk of the spleen actually rupturing. It's fragile when enlarged.
Ah, so that's why people with mono are told to avoid contact sports.
Precisely. Physical activity is restricted during that acute phase to prevent rupture. Diagnosis is usually confirmed with the monospot test, looking for those heterophile antibodies.
Okay, now, let's shift gears to the truly neoplastic disorders. The malignancies.
Right. The big categories here are the malignant lymphomas, the leukemias, and something called Plasma Cell Dyscrasias.
Let's start with lymphomas. You said there's a crucial distinction right off the bat.
Absolutely. Between non-Hodgkin lymphoma, NHL, and Hodgkin lymphoma, HL. They are fundamentally different diseases.
How so? What's the difference with NHL?
NHL tends to have origins that are multicentric, meaning it can pop up in various places, often outside the lymph nodes, to extranodal sites. And it involves a diverse range of cell types, B cells, T cells, or even NK cells.
Okay, so NHL is widespread and varied. What about Hodgkin lymphoma, HL?
HL is usually different. It typically arises in a single lymph node or a single chain of nodes. It's much more localized initially. And the absolute defining feature, the diagnostic hallmark, is the presence of the Reed-Sternberg cell.
Describe that cell for us. What does it look like?
It's distinctive. It's a large, atypical cell, often quite large, and classically described as having two nuclei that look like mirror images of each other, sort of like owl's eyes. Seeing that cell under the microscope is the diagnosis of HL.
That's wild. But wait, I read somewhere that this Reed-Sternberg cell, the defining cell, actually makes up less than 1% of the tumor mass in Hodgkin's. How does that even work?
Isn't that fascinating? It's true. The bulk of the tumor in HL is often made up of reactive inflammatory cells, lymphocytes, macrophages, eosinophils that are attracted to the site.
So how do pathologists even find it if it's so rare? And why is it the defining feature if it's barely there?
Well, finding it requires careful examination, obviously, but its presence, even in small numbers, signifies a very specific underlying disease process and Likely a specific genetic signature driving it. It tells us this cancer is fundamentally different from the NHLs, and that dictates the treatment approach and prognosis. Its rarity doesn't diminish its biological significance.
Okay, that makes more sense. So let's dive into some NHL subtypes. They're not all the same, are they?
Not at all. Huge differences in behavior. For example, you have follicular lymphoma. This one derives from those germinal center B cells we talked about earlier.
Okay.
It's usually slow growing, what we call indolent. Patients can live with it for years sometimes.
But there's a catch.
There's a significant catch. It has a tendency to transform over time into a much more aggressive type, often diffuse large B-cell lymphoma.
And that one's bad news.
Very bad news if not treated promptly. It's highly aggressive, rapidly fatal if you don't intervene quickly.
And then there's Burkitt lymphoma.
Right. At the extreme end of aggression sits Burkitt lymphoma. It's one of the fastest growing human cancers known.
Wow.
In certain parts of Africa, the endemic form famously presents as a tumor in the jaw, especially in children. And it has a very strong link to that same virus we mentioned earlier, EBV.
That speed is just terrifying. It really highlights how quickly these genetic mistakes can replicate.
It absolutely does.
Okay, let's circle back to Hodgkin lymphoma.
Mm.
You said it often starts localized. Who gets it?
It has a distinct bimodal age distribution. There's a peak in early adulthood, say 15 to 40 years old, and then another peak in older adults, usually over 55.
And how does it typically present?
Usually as painless swelling or enlargement of lymph nodes. And characteristically, it's often above the diaphragm, initially nodes in the neck, the supraclavicular area above the collarbone, or in the chest.
Any other signs to look for?
Yes, for staging and prognosis, we look for the presence of what are called B symptoms.
Any symptoms?
It's a specific cluster. Unexplained fever, drenching night sweats, like soaking the sheets, and significant unintentional weight loss, usually defined as more than 10% of body weight in 6 months.
And what do those B symptoms mean?
They're clinical markers that suggest the disease is more systemic. It's spread beyond just the initial lymph node group. Their presence generally indicates a more advanced stage.
Okay, let's move on to the leukemias now. What's the core problem there?
With leukemia, the fundamental issue is the malignant proliferation of immature neoplastic cells, those blast cells again. But this time, they primarily diffuse throughout the bone marrow itself.
So they take over the factory.
Exactly. They crowd out the normal, healthy cell production lines, and then these malignant cells spill out into the bloodstream and can infiltrate other organs, the liver, the spleen, even the central nervous system.
How are leukemias classified?
Primarily based on two things. The dominant cell type involved, is it lymphocytic from the lymphoid line or myelogenous from the myeloid line? And second, the typical course of the disease, is it acute, rapid onset, immature cells, or chronic, slower onset, more mature but still abnormal cells?
Giving us four main types: AL, CLL, AML, CML.
Precisely. Acute lymphocytic leukemia, chronic lymphocytic leukemia, acute myelogenous leukemia, and chronic myelogenous leukemia.
And connecting this back to specific genetic changes, CML is the famous one, right?
Absolutely. CML is the poster child for targeted therapy in cancer, really. More than 90% of CML cases are defined by the presence of a specific genetic abnormality called the Philadelphia chromosome.
What is that exactly?
It's a translocation, a swap of genetic material between chromosome 9 and chromosome 22. This creates a fusion gene and a resulting fusion protein that acts as an always-on signal telling the myeloid cells to proliferate.
And identifying that specific target.
Tied directly to the development of drugs called tyrosine kinase inhibitors, like imatinib. These drugs specifically block that abnormal signal. It revolutionized CML treatment. A huge win for molecular medicine.
Incredible. What about the acute leukemias, all L and AML?
Acute leukemias, think AL, which is more common in children, and AML, more common in older adults, are characterized by a really abrupt onset.
And the symptoms.
The symptoms are primarily a direct result of the bone marrow failing because it's so packed with blasts it can't do its normal job.
So
You get fatigue and weakness from anemia, lack of red cells, increased risk of severe infections from neutropenia, lack of neutrophils, and easy bruising or bleeding from thrombocytopenia, lack of platelets. This bone marrow failure, essentially.
Is there any immediate life-threatening complication with acute leukemia?
Yes. A critical one to know is leukostasis.
Leukocytes, what's that?
Imagine the blood getting thick and sludgy because it's just overloaded with blast cells. When the circulating blast count gets extremely high, say over 100,000 cells per microliter, the blood viscosity increases dramatically. It's like trying to push wet cement through tiny blood vessels. This can physically obstruct blood flow, especially in the delicate circulation of the lungs and the brain. It's a medical emergency.
Scary stuff. Okay, what about the chronic leukemias then? CLL and CML.
In contrast to acute, chronic leukemias usually have a much slower, more insidious onset. They typically affect older adults.
Let's take CLL.
Chronic lymphocytic leukemia, CLL, is actually the most common type of adult leukemia in the Western world. It's often asymptomatic at diagnosis, maybe just picked up on a routine blood test showing isolated lymphocytosis, too many lymphocytes.
Is it generally slow growing?
Often, yes. Many patients have an indolent course. But one of the major clinical problems associated with CLL down the line is hypogammaglobulinemia.
Meaning low antibodies.
Exactly. The malignant B cells in CLL don't function properly to make antibodies, so patients develop an inability to produce adequate antibodies, leaving them highly susceptible to recurrent bacterial infections. That's often a major cause of morbidity.
And CML. We know it's defined by the Philadelphia chromosome.
Right, and its clinical course typically progresses through 3 distinct phases. It starts with a chronic phase, which can last for years and is often well controlled with targeted therapy now.
Yeah.
Then it can enter an accelerated phase where the disease becomes harder to control, counts rise, and symptoms worsen.
And finally.
Finally, it can transform into a terminal blast crisis phase. Here, the disease rapidly progresses and clinically resembles an acute leukemia with a high number of blasts. It becomes very difficult to treat at that stage.
Okay, one last category, plasma cell dyscrasias. What's the main one we need to know?
The big one is multiple myeloma. This is really a B-cell malignancy, but specifically of the terminally differentiated B cells, the plasma cells, whose job is normally to make antibodies.
Who tends to get this?
It's typically a disease of older adults, usually people over 60.
And what's the core pathology? What do these malignant plasma cells do?
They proliferate uncontrollably within the bone marrow. That's the primary site. But crucially, they secrete substances that activate osteoclasts.
Osteoclasts. Those are the cells that break down bone.
Exactly. So the malignant plasma cells essentially trick the body into destroying its own bones from the inside out. It's a major problem.
Reading too.
This causes characteristic osteolytic bone lesions, basically punched out holes in the bones, which leads to severe bone pain, an increased risk of pathologic fractures, bones breaking with minimal trauma, and dangerously high levels of calcium in the blood, or hypercalcemia, as calcium leaches out of the damaged bone.
Ouch. Are there chemical signs too? You said plasma cells make antibodies?
Yes, these malignant plasma cells often produce a huge amount of a single type of antibody, or just a piece of an antibody. This shows up as a monoclonal spike, the M protein, on a test called serum protein electrophoresis.
M protein.
Or sometimes they just produce the light chain component of the antibody. These are called Bence Jones proteins, and they get filtered into the urine.
Are those harmful?
Yes, Bence Jones proteins are actually toxic to the renal tubules in the kidneys. Over time, this can lead to significant kidney damage and even renal failure, which is another major complication of myeloma.
So how is multiple myeloma typically diagnosed? Is there a checklist?
There's often a classic triad doctors look for. First, evidence of increased plasma cells in the bone marrow itself, usually needing more than 10% plasma cells on a bone marrow biopsy.
Local.
Second, the presence of those characteristic lytic bone lesions seen on imaging, like X-rays or CT scans.
Right.
And third, detection of either that M protein spike in the blood serum or the Bence Jones proteins in the urine. Finding these elements together strongly points towards myeloma.
Wow, okay. So just to recap then, we've really covered a huge spectrum here.
We really have.
Started with the non-neoplastic disorders, the lack of cells in neutropenia, and the viral proliferation in mono. Then moved into the solid tumors of the lymphoid system, the lymphomas, making that key distinction between NHL and HL, using the Reed-Sternberg cell as the guidepost for HL.
Right, the hallmark cell.
And finally, we covered the circulating cancers, the leukemias, thinking acute versus chronic, lymphocytic versus myelogenous, and remembering key genetic markers like the Philadelphia chromosome. And we finished with multiple myeloma, that plasma cell cancer that attacks the bones.
Exactly. And if you try to connect all this back to the sort of bigger picture takeaway, the common thread, I think, running through all these diverse disorders is the disruption of that normal, tightly regulated process of hematopoiesis, of blood cell production and function.
So it's all about loss of control.
Fundamentally, yes. Whether the pathology is driven by a simple absence of cells or interference from a virus, or these complex genetic changes like translocations that lead to uncontrolled proliferation. The system's failure to maintain balance and control is ultimately what causes the illness.
That's a great summary point. Okay, so as we wrap up, here's a final provocative thought for you, our listener, to consider, drawing from the implications in the chapter. When treating acute leukemias, the initial chemotherapy is designed to cause a massive and beneficial die-off of those malignant blast cells.
Right.
Kill the cancer.
Right, that's the goal.
But this huge sudden cell death can trigger a dangerous complication called tumor lysis syndrome, where the contents of all those dying cells flood the system and overload the kidneys.
Yeah, it's a serious risk. You get high potassium, high phosphate, high uric acid.
Exactly. So the question to ponder is this. Given that risk, how does the necessary prophylactic management, things like giving fluids, giving drugs to lower uric acid, carefully monitoring electrolytes before the problems even started, how does that proactive approach represent a true clinical victory, not just in fighting the cancer, but in managing the potentially lethal consequences of a successful treatment? Think about protecting the patient even when the cure itself is working powerfully.
That is a deep dive into the white blood cell disorders complete. It was great digging into this with you. Thank you for joining us.
We hope this helps clarify Chapter 24 for you. We'll catch you on the next deep dive.